during the ceremony, the priest goes, "The song you're gonna sing to make sure."
A big picture of me on the screen?
Oh, yes, that is definitely it.
This is Google Hangouts. This is a Hangouts on Air thing, and you can broadcast live, and then it records it. The thing called Webinar Jam, which used Google Hangouts, but then I realized I don't need Webinar Jam. In the comfort of your own home, if you want, you can record yourself singing or doing whatever.
Who wants to hear that?
She might be a good singer. We might want to hear it. All right.
Baby.
All right. How y'all doing today?
Great.
Did everything go well with the information from last week? We'll come back and we'll go through a few things and review because we have plenty of time for that today. What I want to do first is I want to start by talking about the changes that are going to occur in the mother, talk about the process of labor and birth, and then finish up with how the infant adjusts to living outside the mom, and then finally finish it off with lactation. So we have a few things to talk about, and it should be easier to follow along than last week when I was just going through wasn't the notes and everything. But sometimes I do that, but the reason why I do that, and I used to be really, and I'll explain, I used to be really to the letter, like making sure I go step by step by step by step through the notes. But what I've realized through taking classes in how the brain learns and how we learn, you want to focus on the stuff that is the most important at the beginning, and because learning goes like this. So there's a time like right now that I'm talking to you, so remember this maybe, hopefully. But there's a time when the brain is primed to learn. That's the prime learning time. And then after a certain amount of minutes, then you're going to dive off and you're not going to remember anything I say. That's what we have. No, that's why I have you do change up activity. Rather talk to someone about something, because it jogs your memory, gets you in a different mode. So instead of bottoming out, you kind of just go down the little bunny hill. And then there's a period after that you're going to be in your second prime learning window, and that's when I hit some other information. So I'm not following the notes per se all the time because I'm trying to hit on the stuff that I feel is the most important, the best. And then the other stuff is kind of like, because if you don't quite get it, or if we cover it during a trough, it's not as big of a deal. That's kind of why I jump around. So hopefully you can follow me. If you're not sure where I am, just ask. Say, hey, I'm trying to follow you. Where are you in the notes? And I'll tell you. All right? Don't worry. You can always ask. I don't mind. I'm not going to get angry at you. Hopefully you figured it out by now. I don't get angry at people. Helps you, right? It helps you be a better student by yelling at you, right? All right. So let's talk about the anatomical changes to the mom. Some of these are pretty obvious. Okay, so some of the obvious changes that are occurring. The female reproductive organs and breasts become increasingly vascular and gorged with blood, preparing her for number one, birth, and then also nourishing the child after birth, if that's what she chooses to do. Obviously, the uterus is going to enlarge dramatically, but that's because she's got a growing embryo and fetus inside of her. So here, this is the picture that you see. Most notable is the uterus. Larger and larger. The side part to this is that there were things where the uterus is now. So what's happening is as the uterus takes up more space, it's compressing and squishing and moving out of the way the other organs, like the digestive organs, which are mainly in this abdominal region. So the woman is going to have issues with heartburn, which, as you know, if a woman has lots of heartburn, then the baby's going to have lots of hint, right? So if she doesn't have heartburn, the baby's going to be bald? I don't know. So anyway, the heartburn is a common symptom because the uterus is pushing up on the stomach, and so the stomach isn't as large as it was, so it's a higher chance of reflux. Also, higher instance of or higher chance of things like constipation, because again, the large intestine and the colon and the gastrointestinal organs are being compressed, so things aren't able to move as well as they may have, especially in the later parts of pregnancy. And then also, as she gets further along toward the end of the pregnancy, she urinates more frequently. But that's because, again, you've got a squished bladder because the uterus is growing so large, and the uterus is located posterior to the bladder, so it's right there. And also, then you got a little baby that's starting to learn how to kick, so it's kicking the bladder every once in a while, and everything's just getting squished. So if you think about things just getting squished, it kind of explains a lot of stuff. But there are some things that are also happening to kind of get the woman into, to get ready for delivery. And I'm going to talk a lot about that today, about considerations for getting ready for delivery. But one of the things that happens is the woman's body's like connective tissue structures, like the ligaments and the tendons, become more flexible. The joints become more flexible. It's a hormone secreted called relaxin. So a woman will just naturally get more flexible. It was kind of cool when I was finishing up chiropractic school. We would take care of actual patients. There was a woman who came to us who was pregnant. It was funny because she used to have problems with her low back, and we used to stretch her out. And it was funny because as she got further along in her pregnancy, she became more and more flexible without doing anything. So it was kind of interesting to see how that relaxin, as it kicks in, naturally makes a woman more flexible. The idea is the pelvic bones need to be more flexible because you got to fit this baby's head through the bottom of the ring of the pelvis, so that way it can be delivered. And we'll talk a little bit about that. Head not fitting through the, yeah, exactly, pop up. The baby's head not fitting through the birth canal and things like that. What else do we have? A shift in the woman's center of gravity. Women suffer from low back pain very frequently because now they know what it's like for men to have a big pot belly and have back pain, because you got all this weight anteriorly, and it's increasing the stresses placed on the low back in the back. So it's not unusual for women to have problems with getting comfortable in low back pain. Normally, a woman is going to gain, they say, about 28 pounds. Some of that's from the fetus actually getting larger, depending on the weight of the baby. Sometimes the baby is 6 pounds, 7 pounds, 8 pounds, 9 pounds, whatever. So that in itself increases the weight. She also has more blood that her body is going to produce. So that also increases the amount of weight that she has within her, or amount that she weighs, I should say, because of the increased related to the blood. Also, there's amniotic fluid causes increase in weight. If you undergo any sort of muscle training where you're working out your muscles so that they get larger, because that muscle gets larger, it's going to weigh more, right? Well, the uterus is a big bag of muscles. So as that uterus gets bigger and larger and stronger and it hypertrophies, it's also going to get heavier. It's just like a muscle getting heavier. So there are a lot of considerations. Women think, oh my gosh, I've gained so much weight. Well, yeah, but a lot of that comes from things that are secondary. But what you can also see is that the woman is going to go through metabolic changes in how she metabolizes her food. And so you're going to see that she's going to have fat stored differently than she would if she's not pregnant. This is sort of a natural thing that happens in women so that they're prepared to continue to nourish the embryo and the fetus in case she has to go through a stretch where she doesn't get a lot of food. See, so the body naturally kind of prepares itself and prepares the woman for the potential things that may be happening. Let's see what else. Morning sickness. Morning sickness is a common thing, and while they can't pin it exactly to that, they believe that it has to do with HCG level. So this caused a problem years ago when they would, when a woman would start having morning sickness, started producing the HCG. Give the woman a morning sickness drug or pill called thalidomide. Anybody heard of thalidomide? Yeah, because you're probably like me, you know, old enough to hear of this stuff because it kind of affected our generation. What you gotta do is go to Google and put in thalidomide, baby. This is if you know how to spell thalidomide. Yeah, this is what we got. See, so what happened is they would take this drug, not realizing it was a teratogen, and it affected the development of the embryo at the time that she took the drug, which was when the limbs were developing. Remember, when a woman finally discovers she's pregnant, starting to look pretty darn human. So what was happening, unfortunately, is these women were taking drug to help them with their morning sickness, but what was happening is it was affecting limb growth, and so you had what they called thalidomide babies, and they still, I guess, they still have thalidomide today, but it's a not so harmful, obviously. But that was an issue. We talked about heartburn already. Her kidneys are going to produce more urine because she's also processing the metabolic wastes of the fetus. Vital capacity, respiratory rate is going to increase. Much to you right now, but what that means is that she's going to breathe more often, and the amount of air that she can take into her lungs at a given time is going to that she's getting, her lungs become more efficient, I guess, if you want to look at it that way, because there's less space. This uterus is pushing upward on the bottom of the diaphragm, and the lungs sit on top of that. So the lungs can't expand as much as they used to. So the woman's lungs accommodate and become more efficient. So they can process more gases and respirate more efficiently, if you want to look at it that way. Blood volume increases by up to 40% by the time she is almost through the pregnancy. That's quite a bit. It's a lot of fluid. Usually what happens is her cardiovascular function is going to change too. Mean blood pressure decreases during the second trimester. Second trimester is like the great trimester. There's the first trimester, which is usually lousy. Second trimester, from what I've heard, I haven't gone through it myself personally, but what I hear is that second trimester is like the most pleasurable because of the three, because you don't really look pregnant, you don't really feel pregnant, you don't have morning sickness, so you're kind of like in that sweet spot. Third trimester, the getting much larger, and then you start to have physical issues and manifestations of being pregnant that make it a little less enjoyable. Okay, so that's it. That's kind of what's happening here. So basically, in a nutshell, the woman's body is changing in ways to, number one, prepare her to deliver the baby, but also number two, to nourish the baby after it's born, and also to support the growth of the fetus as it's getting larger. Okay, so let's talk about birth, parturition it's called. Usually about 15 days within the calculated due date, which is 280 days from the last menstrual period. Remember, we talked about how they say a woman's actually pregnant before she is pregnant. Calculate off of the last menstrual period, which not physically get pregnant during that time because there's no endometrium, right? And ovulation hasn't happened and all that stuff. We know that, right? You understand? They get that? So anyway, they calculate, they take 280 days after the last menstrual period and then say, this is your due date. Now, depending on your healthcare practitioner or the healthcare practitioner, some of them are really like to the book, to the letters, like if the baby doesn't come out by that date, then we're scheduling a C-section and we're ripping that baby out of you, okay? We're gonna take it. Some practitioners are like, well, the baby comes when it comes. conservative healthcare practitioner, I guess you'd say. Not one of those crazy chiropractors. I consider the chiropractors probably would consider me pretty crazy. A lot of things medically that they wouldn't do, or buy into things medically that others wouldn't do. But what I'm saying is, from a more conservative standpoint, who knows better? A cardboard thing that when you put in the date of your last menstrual period and it calculates the due date, does that card know better, or does Mother Nature know better? Right? I would think. So the baby comes usually when it's ready, except for extreme circumstances. The baby will come when it's ready. But that's my spin on the book. And so it depends on the practitioner, and it also depends on medicine, because the pendulum swings. So sometimes the trend is we'll just let the mom deliver when her body says she's ready, and then it'll swing the other way and say, boy, it's dangerous to let the mom go beyond the due date, because if it does, the baby gets too big, can't get out, and then it's so it really depends. It really comes down to the individual healthcare practitioner and what they feel. I've heard stories about people who say, oh, we better induce labor because this baby is X number of days past the due date. It's going to be huge. It comes out, it's like 6 pounds. Yeah, that's a huge baby, let me tell you. Right? So I mean, it's like I said, it's so up to the individual practitioner. So it really doesn't matter. But what we do want to talk about is what is going to initiate labor? What is going to cause labor to begin? And what we're looking at are the estrogen levels. Remember, we have two hormones that are involved. What are the two hormones involved with keeping the uterus intact so that we don't shed off the endometrium? What are those two hormones we talked about last week? One was on the screen. Estrogen. What's the other one? Starts with the P. Progesterone, right. And remember we showed you that graphic where estrogen, well, here you go. Here's the first term, stage. That's not what I meant, but hey, why not? Have a party. First term is stage. World is a stage. Got it? All right, so remember that graphic? What I was trying to do, remember that graphic where we saw that estrogen went like this and progesterone went like this? Remember how it kind of tailed off? And I'm exaggerating outward, but remember how progesterone started to go down? So the thought is, this is where what I read, I don't remember where I read it anymore, but the thought is that as long as estrogen and progesterone are progressing together, then we're not going to set the stage for labor. But what happens is when progesterone starts to tail off, it takes off the inhibition of estrogen. So let's say, what we're saying here is if estrogen were left unto its own devices, it would, quote unquote, induce labor much earlier. But progesterone is present, and progesterone inhibits estrogen from having its effect on the uterus at all. Does that make sense? So it's like a prohibitor. But once the prohibitor starts to tail off, once the progesterone starts to go away or go down, now we are removing the inhibitor on estrogen from doing what we see here on the screen, which is inducing the oxytocin receptors on the uterus. So it's basically bringing to life or activating or turning on the switch for the receptors on the uterus to accept oxytocin. Does that make sense? Yes, question.
Does this happen right away?
It's going to be gradual.
Okay.
So there's the thing that we call false labor or Braxton Hicks contractions. The start of it. That means that the uterus is starting to contract, but it's not a uniform contraction like it happens in real labor. So those oxytocin receptors are coming alive. They're coming online, but it's a gradual process, little by little. And that's because the progesterone just doesn't tail off. It gradually gradually goes out. So as the progesterone starts to tail off, now we start to see that some of these receptors are coming online for oxytocin. Yes, go ahead.
There was a question
Okay.
in that.
No, the question, so people can hear it, okay, because sometimes the microphones don't pick up so well. The question was, there's a question on the quiz, or the first quiz, about what hormone has an effect on the corpus luteum. The corpus luteum secretes estrogen and progesterone. So that would not have effect on the corpus luteum. What has an effect on the corpus luteum is the HCG. Because the HCG is what keeps the corpus luteum intact so that the corpus luteum can secrete the estrogen and progesterone. That makes sense?
Mm-hmm.
So it's the HCG. I hope that was an option.
I think.
Okay,
Remember all of them.
but that's what it is. So when we have implantation of the blastocyst, the wall of the uterus, then we start to develop the chorion. Then the chorion secretes HCG, which goes back to the corpus luteum, keeps the corpus luteum around, and then when the corpus luteum is kept around, it secretes estrogen and progesterone to keep the uterine lining intact, so that she doesn't. Does that ring a bell?
Yes.
Okay. Even if it didn't, you'd say yes anyway, right? So
Yes.
so hopefully yes.
I do remember.
Okay. Okay, now you remember. Okay. So that's great, great review. Thanks for bringing that up, so we can go through that again. All right, so oxytocin. So what we're seeing is that the receptors for oxytocin on the uterus become active. And so now we can receive oxytocin. So if you think of that second messenger sequence that we talked about the first class, so you have the hormone that binds to the receptor, which causes a change to the receptor, which causes the release of the G protein. The G protein goes over, locks into that enzyme, and then that enzyme causes a change somewhere else. Okay, so that's the one we're talking about. Does that ring a bell? Hopefully. Okay, so what's happening now is when we have oxytocin interacting with the uterus, it's going to lead to muscle contraction of the uterus. Here, so the time stimulates the uterus to contract. And it's also going to stimulate placenta to release prostaglandins, which are going to, once we get into the throw of things and we start really getting into labor, stimulating more vigorous contractions of the uterus, and also a positive feedback loop back to say we need more oxytocin. So as the uterus starts to contract, it's going to cause the cervix here to stretch. And as that stretches, it's going to send a feedback signal back to the pituitary gland saying, give us more oxytocin. Right? Not to the pituitary directly. Brain, and the brain says, okay. Remember, pituitary gland, we have the anterior pituitary and the posterior pituitary. Anterior pituitary creates its own hormones, right? The posterior pituitary, those stores hormones. Two of them. One is antidiuretic hormone, the other one is oxytocin. Okay. I like it when things start to fit together anyway. All right. So what happens is, as we get more oxytocin receptors coming online, we start to get a coordinated, more vigorous contraction, which then we call labor. We'll talk about labor in a Okay, so let's just okay. I can tell you a labor story. All right. So, okay, let me talk to you about something related to labor that the book doesn't talk about, but it's something. All right, so how I came to know this, my wife, when she was pregnant with our first daughter, didn't want to have, as she want to be hooked up to IV and all this stuff, natural childbirth. My sister, my older sister, who already had children, so a couple children, two. She had two children, and she talked to us about this birthing method that she. But it was natural. It was called the Bradley method. Has anybody ever heard of the Bradley method? Heard of it? Okay, you've heard of it, but have you had children or anything?
I had a child, but I didn't use it.
You didn't use it. Okay. Did you even look into it, or you just heard of it?
Well, I've heard of it, but all natural really kind of.
Okay. Yeah. So the Bradley method is a method that was developed by this doctor. Last name was Bradley. Developed this methodology for preparing for a natural childbirth so that you could all the things my wife didn't want to do. Okay, with giving birth in a hospital and stuff like that, that's fine. Of course, we're going to have birth in a hospital, and that's what's nice about the Bradley method is that you can use it for home birth or you can use it for whatever. But the idea behind it is preparing the mother for labor and delivery, so she knows what to expect, so she doesn't fight it, basically, and so she kind of goes with what her body is doing. And it was a cool thing to go through. Cool thing because I thought I knew a lot, but I learned a lot. I saw more videos of babies being born than I thought I would ever see. But it was okay because I knew what to expect. I knew exactly what to expect before, during, and after. I was very well informed. So was my wife. And the idea is, like, if I were to say, hey, everybody, let's go run a marathon. Okay, we're going to run a marathon. How would you prepare for the marathon? Would you say, okay, well, in 9 months, I'm going to run this marathon. Lord help me. Or do you start training and preparing? And so the idea is you start training, preparing, and get your body ready so that way you can roll. And so, so one of the things they talked to us about, they helped us understand what labor contractions were going to be like. I'm like, I don't know. I'm not a woman. I don't even know what it's like to have a uterus, so I don't know. So what they did is they prepared us for what the uterine contractions were. And so so I was the birth coach. So I'm supposed to help my wife through this and relax through the contractions and stuff like that. And so what we were supposed to do is we were supposed to practice just understanding how the uterus would contract. And it was like this, and correct me if I'm wrong for those of you who had children and, delivered them yourselves. But it was, they said, well, what happens is it's just this gradual tightening, and then it contracts and it holds for a while, and then it releases, slowly. Practicing and stuff. Like, okay, this is cool. I understand how this is all working, what my wife's going through. So they also talked to us about the emotional signposts of labor. And this was the most helpful thing for me when my wife was getting ready to have our first daughter, because it was like the light went on and I knew what was going to happen. And so I'm going to teach you the emotional signposts of labor so you know what they are. And I think I have them referenced in the binder document. And this is so that you don't end up going to the hospital or taking someone to the hospital before they're ready and then being there in what I call the hell of the hospital, which is just sitting there waiting for the baby to come. So the first emotional signpost of labor is that she's really excited, she's really giddy, she's really happy. And so my way of testing this with my wife was to keep telling her the horrible jokes I always tell her, but she laughs a little bit. So I was kind of talking to her and seeing her general mood, because when the woman first starts going into labor, she's really excited, she's really giddy, she's really happy. And if you take her to the hospital at that point, she's got a long way to go yet. Okay, if you were to see how far she's dilated, if you don't know how far she's dilated means, we'll cover that in a little bit. But if you check to see how far she was dilated, chances are hardly anything. So you'd be sitting there waiting. So that's the first emotional signpost. And what we were told is don't take her into the hospital then, because if you do, then you're going to be hooked up to a fetal monitor, which you don't want to be hooked up. Fine. So the second emotional signpost is she gets serious. So now what happens is my jokes, which she was at least humoring, not laughing anymore. And the reason why is because the labor is getting more intense. Contractions are getting stronger. They're becoming a little bit painful, becoming uncomfortable. And so what's happening is more serious. It's to the point, and they said too, that it's kind of to the point where before this, if she were to cross the road, she could walk across the road having a contraction and it wouldn't stop her in her tracks and she could keep walking. When you hit that second stage, now the contractions are so intense that she actually has to stop. Wait for the contraction to pass, and then she can continue to walk. I don't advocate pushing her out in the street and saying, walk across, tell me, see what happens.
She didn't make.
Don't have to do that, right? So you get serious. So my wife, she has a very high tolerance for pain, apparently. And I also performed something that was really helpful to her, which I would take my fist and I would just push it into her low back right about here when she was having a contraction, and it made the contractions more bearable. So I was just, laying into that thing, leaning in. I was putting all my body weight into her low back, and she tolerated okay. Then the third stage is what they call transition. And this is where you better have her pretty darn close to the hospital or wherever she's going to deliver, because what comes right after transition is pushing, right? So this is where you hear the caricatures of women who are, in labor, and they start screaming at the husband and saying, you did this to me, and, I'll never forgive you. They start flying. But for my wife, she just started crying. So she just gets very emotional at that point. As another child at home, she misses the other wife. She missed. That was what it was. But we weren't to the hospital yet, so we were in trouble. So what had happened for us was she was in labor all day long, and I was timing these contractions. And she was doing pretty well. I'm like, how are we doing? I'm doing fine. I'm timing them. And it's like, okay, they're 5 minutes apart. How you doing? I'm doing fine. Okay. Now I live in Kiel. We were going to Sheboygan. It's like a 40-minute drive. How you doing? I'm doing fine. Haven't called the doctor yet because the doctor's going to say, come in. Okay. All of a sudden it's like 2 minutes apart. And I'm like, how you doing? Going, okay, good, let's go. So then we were there, we were on the way, and we were still about probably 15 minutes from the hospital, and she went in. So I'm like, okay. So we're about 5 minutes away from the hospital. She goes, I think I have to push. And I said, I think you have to wait, because otherwise we're going to have the baby here. So then so that's the last emotional signpost. And then after that, if you know that she's in transition, she's going to be pushing wanting to push within the next couple of minutes. Got to the hospital at 7 o'clock. And we were already pre-registered, so we were okay. I called the doctor on the way. Luckily, she was in town. She's like, oh, how far apart are the contractions? Like 5 minutes. That was like 2 hours ago. But anyway, so she came. She's like, okay. So she came in. She said, I'll head in. Got to the hospital at 7 o'clock. We were pre-registered. So then they asked her, well, do you need a wheelchair? No, I'll walk up. I said, you get in a wheelchair, because she had 3 contractions while she was at the desk. So then 7:05, we get her up into the room. She's up in the room at 7:05, and 7:17, Brianna was born. That close. So, I mean, we were really down to the wire. And our doctor actually came in as Brianna's head was crowning. I mean, that's how close we were. Get close. with Brianna. Not so much with Ava, but
And she could,
yeah, she did that along. She was and the nurse kept saying, "You are amazing." She's saying this to my wife. Oh my gosh, this is so close. But we made it. So the emotional signposts of labor are really helpful to you because it kind of lets you know how far along things are progressing. So the first one is she's giddy, she's happy. The second one is that she gets very serious. And then the third one is the transition. So make sure that, and it's funny because if you're ever around a woman, if you ever happen to be in an environment where you're around a woman who's going through labor, kind of watches this. It's kind of cool to see how that really does play out. It's interesting. Or back to, if you can remember that when, you know, we had a child or if someone else had a child, it's pretty cool to see that. Anyway, that was my labor story. All right. So anyway, so when we look at the stages of labor itself, we have several different stages. Once she gets to the point where labor is in full swing. So what we're looking at is basically what we're concerned about. Wait for my pen to come online here. What we're looking at is this, the cervix right here. So as you know, if you remember your anatomy, we have the vagina, which becomes the birth canal. We have the bottom of the cervix, which has an opening, which is called the bottom of the uterus, which has an opening, which is called the cervix. So when the woman becomes pregnant, what happens is we get a thick cervical plug that forms here. God, I had children, so I can understand this. All right, so anyway, I didn't have children, my wife did, but all right, anyway, there's this thick cervical plug that will close up the cervix while she's pregnant. It's a thick mucus plug. So sometime before she goes into labor, she'll lose that mucus plug. That was it. Yeah. Okay. It's kind of bloody and disgusting. There it is. All right. So now the cervix is open. That means that she's getting close. It doesn't mean that it's going to happen the next day. There's no predictor on this. But when that cervical plug moves away, then we know that she's getting closer. But we're watching the diameter of the cervix. And what we want is full dilation, which is 10 centimeters. So what the nurse will do to check the dilation is they will reach their hand in through the vagina, and then they'll feel for the baby's head, and then they'll feel for the edges of the cervix. They'll just do an estimate, dilated, X number of centimeters. My opinion, it's information that the parents don't really need to know. The mother's body will know when pushing needs to happen. The issue, though, we struggle with modern medicine and the way that we deliver babies here in our country is that women usually are medicated to some sort, or maybe medicated to some aspect to make the labor and delivery less painful. Fine, if that's your choice, that's your choice. But it screws with the feedback from the uterus and the cervix to the brain. So in other words, the woman's body might know it's time to push, but she can't determine that, she doesn't feel it, or the feedback loop is kind of disrupted. So in a lot of ways, it's kind of funny to listen to. I chuckle when I listen to the nurses because they're like, well, we have to check to see if you're okay to push. The woman says she's ready to push. She'll push. Go ahead. Yes.
and I know
Yeah, when you feel you have to push, okay.
so I'm trying to do that, and the nurses are. You have to push, you know?
Right, exactly. It's kind of now. I'm a guy, so I don't understand this, but it's kind of like giving away, but you know, it's more controllable, but it's kind of like a bowel movement. You know, when you have to poop, you have to poop, right? I mean, it's like, but it's much stronger, you know, with this, it's that feeling though, like your body just knows it's time.
The
It's time to push.
contractions were it. The only thing that made it help was to push.
Exactly. The body works in like concert. So you knew it was time to push. Your body just told you it was time to push.
Mhm.
You're dealing with, and it's no fault to the nurses, and those of you who are going to become nurses, which is most of you, no fault to you. It's your training. It's what you told you have to do. I could tell you stories about my fights with the nurse when Ava was born. I will. But it's one of those things. So they say, we don't know if you're ready to push yet. They want to check, but they have to check. They have to make sure because they don't want you to try blasting through a non-dilated cervix and then the baby doesn't go anywhere and you end up hurting yourself big time. So the woman may or may not know that it's time to push, but she can only start pushing, or it's only going to work really well when we have full dilation. See here? So if the woman were to reach her hand in here, now this is a little bit bigger than life size, you know, for the screen. But if I were to reach my hand in here and put my thumb and my forefinger, all that I would feel between my thumb and forefinger right here is baby head. Then I know it's time. See, that's what the nurse would have to check for. That's what the nurse is checking for. I'm ready to push. Okay, let's make sure the baby's ready to come out. I was going to have a real big cone head. The baby with a cone head come out? Yeah, so that happens. So this is what we call late dilation. The baby's head is rotated now, and it's ready to come out. So first step is that early dilation. The latter part of the first step is late dilation. The second stage of labor is actually the delivery, the expulsion. Now, here's the thing. I can only speak for babies who are not coming out of a medicated mother. I've seen the videos, and what will happen is the baby will actually help you along during the delivery process. Now, the baby's supposed to come out so that the back of the head is facing the front. So the baby is facing posteriorly. That's the way you want the baby to come up, because if they come up sunny side up, their face is going to rub against that pubic bone and they're going to have a nice bruise. They'll be okay. They're pretty flexible little guys, but rough on them. So the delivery is rough. But what will happen is the baby will come out like this, like you see it. This is the ideal. Comes out like this. And then once the head comes out, the baby will, on its own, it will twist. It'll turn and face sideways, because that's the most ideal presentation for one shoulder to come out. And once one shoulder comes out, then the rest of the baby is going to come out like a greased pig, right? It just comes shooting out of there, depending on how hard mom's pushing. It's like you gotta grab. When Brianna was, for Ava too, when Brianna was born, I remember I asked if I could catch Brianna when she came out. I literally had to catch her because she was coming out so fast. So, and then she looked at me and cried. That was good. All right. So anyway, so the baby will help you along. Now, if it's a baby coming out of a mom who's on medication, the baby might not be as helpful as cooperative because those same drugs are passing through the baby. But so I'm not cracking down on or saying it's not okay to get medication. You do what you need to do. I mean, you do what you want to do, and that's perfectly fine. But the baby will help you out quite a bit. And we have the third stage, which the mom usually forgets about much of, especially after the fact. They're like, oh, I don't really remember that. And that's the placental stage. So now this part of the placenta, the portion of the placenta is no longer relevant. It's no longer useful. Its primary purpose was to nourish the fetus. But now that there's no fetus to nourish, now what happens is that the fetus, the placenta pulls off of the wall of the uterus. The problem is now this is a big open sore, and the mom can lose a lot of blood. So immediately what happens is the uterus undergoes something called involution, where the uterus will start to curl up in a ball and constrict to clamp down on the bleeding. So the uterus will immediately start to get smaller. It'll start to roll up. And it's amazing because you've got this huge uterus that held this fetus within it. And within 6 weeks, it pretty much gets back to its original size. That's pretty amazing, if you ask me. I think that's just phenomenal. So, one of the ways that a woman can help her body's natural process as far as stopping the bleeding is to allow the baby to nurse right away. So if the mom decides that she wants to nurse, one of the best things that she can do to help everyone is to nurse right away. That's a really cool video. I haven't been able to find one like this. I'll have to do some more. But I saw a video of this baby that was born, still connected to the umbilical cord, and they just laid the baby right on the mom's chest. And the baby, on its own, crawled up the mom's chest and latched on and started nursing right away. And they didn't touch the baby. They just threw the baby on the mom's chest, and the baby, his head's flopping around. Babies don't have good control. But the baby did it. It found it and latched on all by itself. Amazing. But that's a great thing that the mom can do, because what stimulates the release of oxytocin after the baby's born is the suckling action of the newborn on the mom's nipple, because that is sending a feedback signal to the brain telling the hypothalamus to produce oxytocin, because oxytocin is what causes ejection of the milk from the breasts. So if the woman decides to nurse and she allows the baby to nurse or latch on right away, what it's going to do, remember, oxytocin also causes the uterus to contract. So it's a natural way to help the uterus contract so that it sort of stops the bleeding. So it's a natural way to do it if you want to do that. Anyway, the placenta comes out, and then we're all good to go. Now, cutting the umbilical cord. I put an article on Blackboard about the umbilical cord, and they call it delayed cord clamping, and the benefits of cutting that umbilical cord right away versus delayed cord clamping. And there's just some information about that. My personal take, if you're going to ask Victor, the dad, and Victor, the guy who watched his children be born, I don't prefer them clamping that cord right away. Like when Ava was born, it was like she wasn't even out for like 2 seconds, and bam, that umbilical cord was cut. And I was really, I would use a stronger word than really angry, but I was really angry about that because we had a birth plan for our doctor. Our doctor wasn't there, unfortunately. We had a substitute doctor because our doctor was gone on vacation right when Ava happened to come around. But we specifically said we didn't want the cord clamped right away. We wanted to wait for a moment to let the pulsating stop, because this is arteries and veins, and it's still pulsating when the baby's born. And we wanted to wait till it stopped pulsating and then cut it. Now the reason for this is because the placenta contains blood, and the baby obviously contains blood, but the baby just got done being squeezed through the birth canal, which is very stressful and hard. And so what happens is the blood can be at disequilibrium. There's supposed to be a certain amount of blood on the placental side, and a certain amount of blood supposed to be on the baby's side. And so the idea is if you let the umbilical cord pulsate and equalize, the blood will go back to where it quote unquote belongs. So you have a nice balance. Then cut the cord, we're good. But if the baby just got squeezed out and you cut that cord right and there's blood squirting all over, that's really tough, because now you don't know if the balance is off. And I think of, what does nature do? What does Mother Nature do? And what Mother Nature does is it allows for the cord to stop pulsating and harden, and then the mom will chew off a little animals. I'm not talking about people. We're gonna make that. That's what you did. You just got in there and bit it off. Yeah, kind of like a Johnsonville sausage, right? Just that casing. But I mean, you think about what nature does and what nature allows for, and sometimes, and this isn't my statement, but I agree with it. In this country, we treat a woman who is delivering a baby as if she has a disease or a medical condition rather than treating it as a natural process of life. See? And part of that's just risk and liability. Because if the baby dies or mom dies, you better believe that there's a lot of liability there, right? So, when I was arguing with a nurse about all this stuff, I felt bad for the nurse because I know she had to do, and it could be, you here. I'm not planning on having more children, but it could be in a room with a parent who's like, hey, this is kind of how I want things and I don't want it. But I know that I was very difficult for the nurses because I'm throwing them a bunch of stuff that is not protocol for them. And so you're kind of going back and forth with, and it didn't help our doctor wasn't there, but you're kind of going back and forth with a nurse, and she's trying to do what she's told to do, and I'm telling her not to do what she's told to do. It gets very difficult. But, I just wish, if I had a wish when it comes to delivery and childbirth, I wish that the medical community would look more at what happens in nature and foster that. And there are some places, underwater births and things like that. I mean, some places get it, but some places it's just like, man, you come in and they hook you up to this machine and hook you up to this machine and hook you up to this and hook you up to this. And you ask why? Well, this is just what we do. Okay, but why are you doing it? I mean, why are you hooking a mom up to a fetal monitor to detect the amount of stress that the baby's under? Don't you think that that's stressful to the mom to hear that the heart rate is increasing, the blood pressure, all this stuff? That's stressful to the mom. Very stressful. So why put her through that? The baby will come when it's ready, unless something, really goes wrong. But that's a discussion for another day. All right. So we're up against a break. I've been talking for long enough. So let's take a break. We'll come back at 10:15. We'll talk about how the infant adjusts to extrauterine life. Doesn't that sound exciting? All right. We'll see you in 10.
Thinking back, replaying all 4 of them. My last 2 kids, my daughter, she's 8.
And we'll talk about, we'll talk a little bit about a couple things that we didn't address and aren't really addressed here, but they are important things to consider because you hear about both of them. One is gestational diabetes, diabetic during pregnancy, and it has to do with the hormones, the pregnancy hormones, affecting the glucose. So I do have a video on Blackboard that talks you through it and gives you an heard about gestational diabetes and you want to know what it is or how it works. That's on Blackboard. And then I also have, I don't know if it explains preeclampsia, but there's a video about what it looks like if a woman has an eclampsia seizure and how they, they just, it's a simulation. Preeclampsia is woman has an increased amount of proteins in her blood, and then what the proteins do is they draw water into the blood. So kind of water follows the protein, and so then she has concern for that is if the preeclampsia turns into eclampsia, which is where she has a seizure and then die, the baby could die. It's a serious condition. So they monitor it very closely to make sure that the blood pressure doesn't get out of control. Now, I will tell you, when it comes to preeclampsia, that there are some people not in the strict medical field. And I heard about this when we were going through the prep. That there have been studies done with certain population groups where they never had any toxemia, had any of that. Avoided it was through. So what the woman needs to do is make sure that she high amounts of proteins, high amounts of green leafy vegetables. As long as the green leafy vegetables are through the roof, they were able to eliminate prevent it, I should say, not eliminate, because none of these women had it. They never had it. And it's dietary. So for you, if you're considering having children and you want to, keep that in the back of your mind. Dietary choices that you make are significant, helping you along. But they would do that. They would actually monitor. My wife had to record what she was eating. And they said, you need to eat X amount of green leafy vegetables. And if she didn't, they were like on her, like, you need to eat more green leafy vegetables and you need more protein. And they were working with a low, with a socioeconomic group that was of low income. So they didn't have a lot of money. So they just said, eggs, milk, lots of eggs, drink lots of milk, vegetables. So it doesn't have to be, anything revolutionary, but they were on my wife to make sure that she appropriately because of that, because we're modifying the diet and being strict with the green leafy vegetables, like spinach, kale, stuff like that. Green leafy vegetables, iceberg lettuce, but like helps basically eliminate the preeclampsia. Yeah, go ahead.
When you mentioned diabetes, last week,
Yeah.
there was a question in there about diabetes mellitus, and it said type 1 or type 2. I wrote it kind of, because I got it wrong, and I'm like, wait a minute, the book said one thing.
Was that?
Yeah, it said, it was either type 1 or type 2.
Yeah.
So looking in the book, type 1 was.
Typed in 1 and then it marked as wrong?
No, I typed in 2 and it marked wrong. It said, question asked, diabetes mellitus type blank
Okay.
or absence. So
It's a
since it said
deficiency or
or,
absence.
if it would have just said deficiency, that's type, type 2. Said or absence, which is type 1,
Yeah.
correct answer, I believe, would have been type 1 as far as how the question was graded.
Yes.
But since it had that word deficiency, or are we saying since it said or
Type-
absence?
A deficiency in, well, type 2 diabetes is not due to a deficiency in early stages especially. It's an overabundance of insulin, but the cell is resistant. That make sense?
Yeah.
In the later stages of type 2 diabetes, yes, then eventually when you burn the pancreas out, then it is. But that's in the later stages. But I'll look at that because at least I can modify the question to say, early stages of, or I don't know, I'll have to look at it and see because if that.
Put 2 and.
Let me take a look at it. Let me take a look at it and I'll. Yeah.
I marked it wrong because.
Send me email on it and remind me because then I can. Wow. Cousin, you said? Can hear it on the recording. Her cousin.
Just a little over half.
Her cousin had preeclampsia and delivered at 28 weeks. Pound, how many ounces? Wow, 4 pounds, that's small. Amazing, it made it. That's pretty. Yeah, so those are some things you really, got to think about and consider. We don't talk about a lot in this class because we talk about normal stuff, but common issues that if you work with that population, that you probably will see on a regular basis. So it's a good idea for you to have an understanding of how those work, even though those aren't implicitly said or outlined in here because we talk about what's happening normal. So, all right. Okay, so your second term is going to be the term APGAR, all lowercase, A-P-G-R, although this is an acronym, and actually acronyms are usually capital letters, but there are attendance terms, I always put them as lowercase. When a baby is born, what they do is they assess the baby on their physiological status. They measure their heart rate, their respiration, their color, muscle tone, and reflexes. What they do is they score this out. So APGAR is an acronym for the words appearance, pulse, grimace, activity, respiration. 2 is the strongest rating, 10 is unusual. It's a perfect score. But those of you who had children, you think about, if you remember that, well, maybe dads remember this a little better than moms, because if a dad's watching the delivery, they but their way of rating how well the baby is doing. Obviously, a score of 0 is not good. Or 10 would be like fantastic. But they're just measuring how the baby's doing. Not in your book. Whoops, I got it from website. But if you go into Google and you type in APGAR scoring, We saw this picture last week, and we talked about the adjustments that the baby has to undergo. Really what's happening here is the baby needs to go from relying on its mom for oxygen and nutrients to itself. It needs to be self-sustainable. And one of the first steps in that is maintaining oxygen levels that are sustainable with life or supportive of life. So as in us, what is going to stimulate the baby taking its first breath is increased carbon dioxide levels in the blood. So we have a sensor in our cardiovascular system that monitors carbon dioxide levels. And when those threshold, that's going to initiate all of us taking a breath in. That's why, for the most part, one of the techniques and strategies they would use to help them perform is that they would hyperventilate before they jumped in the water, because when you hyperventilate, you drive down your carbon dioxide levels, and so it takes longer for those carbon dioxide levels to rise again. So therefore, if you want to get a breath holding contest with someone, make sure you hyperventilate beforehand. So anyway, so that's where, again, related to delayed cord clamping, if you don't clamp the cord right away, the baby's still connected to the umbilical cord, which is still connected to the placenta, which still has still is connected to the mom yet, really. So it's not unusual if you have a baby that you haven't cut the umbilical cord, that the baby will come out and it's kind of like checking everything out, but it's not breathing. But sometimes the mom starts to freak out. Oh my God, the baby's not breathing. Baby's okay, the baby's cool. It's just hanging out, its head's bobbing around, taking everything. What the heck happened? It was dark and it was, nice 98 degrees and all of a sudden it's freezing cold and all these lights and people screaming and what the hell, doesn't know what the heck's going on. You think about how traumatic that is on a baby? You think about that? Your whole existence, it's been dark, muffled sounds and nice and warm, and all of a sudden you come out, it's like 70 degrees. It's like it's like being in a hot tub and then coming out and walking into air conditioning. It's like, holy cow, it hits you. Poor kid. So anyway, the kid, if it is connected to the umbilical cord, has an adequate blood supply, it's not going to need to breathe. It's going to breathe only when the carbon dioxide levels get to that point. Then it's going to bring air into its lungs for the first time. Usually it brings it in, and then it starts screaming and crying. And so we start using the lungs for the first time. Now we need to close those shunts that shunted blood away from the lungs. Now we need to close those up so that the blood circulates through the heart and then to the lungs, back to the heart and then to the body. We need to set up that regular circuit that's in us. So those are the structures that we talked about here, which you see at the top, the first blue box. The ductus arteriosus has to close up. The remnant of that is like a ligamentous structure called the ligamentum arteriole. Next structure we see here, the foramen ovale, which is basically a hole that connects the right and the left atria. That has to close up, and that becomes a little spot, a little divot in the heart called fossa ovalis. Okay, so that has to happen within the heart. And then we also have some blood vessels that close off that were connected to the umbilical supply, but that's not as big of a deal because those will just go away and kind of close up. The heart is the one that we are concerned with, heart for the rest of our lives. So this doesn't happen just like that either. It's not like the baby's born and boom, that foramen ovale closes up and we're good. It's a gradual process. It happens relatively quickly, but it's a gradual process. So as you can imagine, the first few hours after this baby is born, it's very difficult on the baby. Everything's really erratic. The respiratory rates are all over the place. Temperature is all over the place in some cases. Heart rate is all over the place. It's just really tough on the baby. It's getting used to being outside of mom. And mom's having a hard time adjusting to that too. She can't sleep because she's worried about the baby, make sure the baby's still alive. An adjustment period for everyone. So the long and short of it is that the baby just needs to get used to it. One of the ways that the baby has to sustain itself is through nutrition. So the mom, oh, there's a third term, circulate. So if the mom chooses to nurse after the baby is born, essentially what's happening. So the infant latches on, stimulates the mechanoreceptors in the nipples by sucking. Infant then, so because of that action, get a signal sent to the hypothalamus. So that sends a stimulus to the hypothalamus. Hypothalamus is going to produce oxytocin and then also send an impulse to the posterior pituitary saying, we need to release the oxytocin. Oxytocin gets released from the posterior pituitary and it stimulates injection of milk, results in what we call the letdown reflex. Now, I kept hearing this letdown. What's this letdown? What's the letdown? Sensation, well, letdown reflex is actually the milk being ejected. But women talk about the letdown, and it's like this feeling that a woman gets when the milk is being ejected or about to be ejected. Some women say it's just like, like a spider web or a wisp of something, across the chest, that kind of gentle. Woman. Sometimes it will happen when the baby just cries. Enough to cause the oxytocin to be released to cause that letdown reflex. So it depends from woman to woman. But this is a positive feedback loop. So what happens here is that as the baby continues to drink, the milk will continue to be released. Run out of milk. So offer the other one to the baby and then you're off again, same thing. So basically, this stays in effect until the mom stops nursing. We also have the actual milk producer. So as the baby nurses, we have the hypothalamus, which releases something called prolactin releasing factor. Up in the anterior pituitary, it stimulates the anterior pituitary to produce and release prolactin. Prolactin then targets the mammary glands, which causes them to produce milk. So as long as the baby continues to nurse, milk will be produced. Now, when the woman first starts producing, or I should say, when the woman starts nursing at the beginning, one of the things that I learned, imagine like a little ping pong ball. That is about the size of the baby's stomach when it's born. Eat a lot anyway. But the baby is, Mother Nature has it that it's expected that the baby is actually going to lose weight before it starts growing again or it starts gaining weight. So if you think about the baby as it's getting closer to delivery, the longer it goes through or toward being full term, the baby just starts to add fat onto its body. It just starts to get fatter. And the reason for this is because it's the anticipation of what's going to happen after the baby's born. That the baby's not going to be very good at eating, for starters, and what it gets from the mom is not going to contain much nutritive value. That's because the first milk that comes through for the mom really isn't milk. It's something called colostrum, which is like this immune cocktail of immunoglobulins or immune proteins that are a natural immune booster for the baby. So some women will nurse just for this purpose, thinking that it will give their baby better health. And it does. But mind you, it's not going to be life-changing. So those immunoglobulins only last for so long, and colostrum is only for so long. So it's not like if you provide the baby with colostrum, that studies show that 30 years down the road, they're going to be less likely to have this or that. It's just to give the baby a nice, good start. After the colostrum runs out, then the true milk comes in, and then that's when the baby starts to hopefully then gain weight. So if the medical community, if a woman decides that she wants to nurse and she wants the help of something like a lactation consultant, what they'll do, weigh the baby, mom will nurse, hopefully everything goes well, and then after she's done nursing, they'll weigh the baby again to see if the baby got the milk, to see if there's a weight. But if you weigh the baby, which they do right after it's born, and then weigh it again when it comes to see the lactation consultant, it drops in weight. It loses weight. The baby. Now, there are advantages to mom's milk. So, mom's milk is best for the baby. That's irrefutable. There's no product out there that beats mom's stuff. It's designed for humans. It's designed for babies. It's especially for that baby. It's readily available. It's the perfect temperature. Everything's great. Okay. However, for a variety of reasons, sometimes milk is not the available option. It might be a lifestyle choice of the mom. It might be that the mom has extra enough milk to sustain the baby. There are a variety of reasons why the baby get supplementation nutrition, formula or something like that. Formula keeps getting better and better. And back in the day where they say, oh yeah, well, formula, if you feed a baby, it affects the baby's stool. Like the stool comes out and it's big, hard, and then it's just formula is changing and they say, well, if you give the baby breast milk, then the poop comes out of the baby and it looks kind of yellowish and seedy. Well, I've seen formulas that babies have had, and I've seen bowel movements by babies that look seedy. What I caution you and to think of is don't be so hard on yourself, or don't be hard on anyone. That's my advice. Don't be hard on anyone. Don't be hard on yourself if they choose to. What matters is, are you feeding your child? You care for your child. You love your child. That's what's important. My wife teaches kindergarten. I always say to her, and she agrees, so she breastfed for a while, and then she switched over to formula. So we kind of have both worlds. And when the kids walk into your classroom, it's not like you look at them and say, formula fed, natural milk, formula, natural milk. You can't tell the difference. What matters is, are you taking care of your kid? Do you love your kid? I know that there are some publications out there and some personalities out there that will tell moms who are expecting that if you don't nurse your children, you're like the second coming of Satan, and that's not true. Okay, you're a good mom. You're a good parent. Feed your child. Also, formula feeding has some advantages. Mom can sleep through the night if she wants to. Make dad get up and feed the baby. And also it allows for dad to have that relationship with the baby too. But there are other ways around that too. The mom can pump and store the milk, and then dad can feed the baby milk too at that time. But when it comes to nursing, eventually what happens is the milk, as the mom continues to nurse, the milk has less and less and less nutritive value. But again, this is natural, because the baby's not only going to be drinking milk, it's going to start to eat other foods and introduce other. So if some women, you hear those women who nurse their kids till they're like 4, 5, 6 years old. Whatever you want to do, fine. That's whatever floats your boat. So if they do this, just it's the nutritive value of the milk goes down as you get beyond it. Usually beyond a year, there's a little bit of nutritive value, but not so much. When the woman decides to finally wean off the baby, it basically comes down to just feeding less often and disrupting these feedback loops that you see on the screen. So not feeding as often, not as much milk produced. And so eventually you get to the point where the mom will quote unquote dry up, but it takes a while. It's not an easy process. It's not easy, put it that way. It used to be an injection that they would give women, dry them up, but they don't do it anymore. We asked our doctor about it because we had heard about this thing, and we asked our doctor, said, "Well, can't you just don't you just have like a shot that you give the mom to dry her up?" And our doctor said, "Yeah, they used to have that, but they don't do it anymore because it affected the pituitary gland. That they don't know what the other side effects to the pituitary may be." Affecting the pituitary to the point where it affects milk production, what else is it affecting? They don't do that anymore. So or that the mom naturally dries up on her own by just disrupting. Now, it's kind of interesting because the last thing it says here in your notes, it says, as long as prolactin levels are high, the normal hypothalamic controls of the ovarian cycle are inhibited, although most women begin to ovulate while still nursing. So that's one of the side benefits that women enjoy while they're nursing is that they don't really have their periods much. Stops for a while, which is okay. But it only works for a while. And then eventually the body kind of gets accustomed to it because obviously women have babies while they're still nursing a baby. So, it isn't forever. And it's not birth control, put it that way, okay? So don't look at nursing as birth control because you're going to be welcoming a new member of the family soon. So anyway, that's where we are. We're all set. So one for each. All right. So, what's that?
Then what do you do if you have like
Yeah, exactly. What do you do with triplets, right?
The run of the litter.
Yeah. Grow a third, I guess, right? Wouldn't that be interesting if that happened, right? All right. Okay, so thinking back to our discussion today, no, we didn't talk about much, but tell me some of the things that happen or some of the changes that occur within the mom as she's getting ready for, as she progresses through pregnancy and is getting ready. Yeah, the organs become more vascular. Yes. Yes, the uterus grows in size, gets larger, bigger, stronger, vascular. Yeah, the progesterone starts to drop, whereas estrogen keeps going up. So when we see that change in the progesterone, that's when we. Yes, relaxin is released, and what does that do? Yes. Yeah.
Ligaments and the.
Yes. So it's preparing the woman's pelvis for birth. So here's one thing that can help women. One of the concerns that people have, and one of the reasons for C-sections is the baby gets stuck, can't get out the birth pelvis thing. And one of the things that women can do while they're pregnant to help them is do what are called pelvic tilts. Exercise. But look better. Okay. There it is. Okay. So pelvic tilt. Bodies, but hey, we'll see if it's on track. Let me just go here. I can just do it. All right. Back is dropping down and now goes back up. See that? Kind of like doing a cat thing, and then did you see that? She's very subtle about it because she's trying to strengthen the core. But what you're seeing is that she's dropping the hips, dropping the pelvis, so the stomach is going toward the floor, and then she's going to reverse it and bring it back up. You see that? That's a pelvic tilt. So if you do the pelvic tilt, that's one exercise that a woman can do several times a day to help increase the flexibility of the pelvis, mobility, and so forth. Another thing, as often as she can, sit pretzel style. So the yoga posture, when you sit in your that kind of sitting like that as often as you can, sitting on the floor as often as you can. Those are great ways to keep the pelvis flexible, pliable, and get it to shown that if a woman is very faithful with those pelvic tilt exercises, that the chance of the baby not fitting through the pelvis to go way down. Pelvis is more pliable, more flexible. So yes, that's the relaxer. Okay, what else? What are some other changes? Yep. And some of that comes from the baby, some of that comes from blood, amniotic fluid, variety of sources. Yep. What else? Yes. So metabolism changes. Sort of her body is preparing for what you would call if she has to fast, or if she doesn't have food available to her. Think of nature. About back in the caveman days, if a woman carrying a child within her, and all of a sudden she has to go a day or two without eating, the body is naturally designed to store food differently, so that way if she goes through a dry spell, then she's able to and herself appropriately. Yes. What else? Oxytocin is released, progesterone tail off, and so then oxytocin starts to oxytocin is there, it's present, but the oxytocin receptors come online, right? Oxytocin can have an effect on the uterus. What else? Letter.
Because
more active, urinate more frequently because of the increased urinary output, number one, and because she's got this fetus, which is bladder, and so. What else? Digestive system, what else? How's that gonna be affected? Constipation, depression of the intestines from the increased size of the uterus and the fetus being. What else? Hairy baby. Heartburn, yeah. Heartburn, you're gonna have a baby with lots of hair. All the wife, oh wow, old wives still, right? Rains on your wedding day, that's good luck? Sure. All right, what else? That,
He said,
that's what, right? It didn't rain on your wedding day, right?
So
You are.
You're on
good.
day 6.
Yeah, right.
Hey, she's riding it out, she's in the honeymoon
So
period.
far,
So good.
She's in her honeymoon period, life is good, life is good.
Another
Better.
month, right?
It gets better, it gets better. Okay, so we also see some changes to the lungs, right? She breathes more efficiently, more effectively. Blood volume increases, so we have a couple of those things happening. Blood pressure is something that you watch. Typically, what we'll see, I know that it says mean blood pressure decreases during the second trimester, then it returns to normal levels during the third trimester. I don't know if I exactly agree with that. I agree with the first part of it, and I agree even with the last part, which says that it returns to normal levels. But most women will see that as the pregnancy gets closer to the end, blood pressure does creep up. So it's not like it goes down and then comes back up and then plateaus. It actually, gradually goes up. So any woman can typically expect to see her blood pressure go up gradually. Now, if it goes up significantly, now we're talking about something else, possible preeclampsia. But for the most part, even if the woman is not preeclamptic, she's going to see a slight increase in blood pressure. All right, so tell me about the emotional signposts of labor. What did we talk about? What's the first emotional signpost of labor? Giddy, she's happy, she's excited. So the recommendation during this point in the development of labor would be to what, if you can? Now we were talking on the break, which you didn't hear, like sometimes you can't. Got to get in, like with our second daughter, no doubt in the early stages of labor, but my wife's water broke. Call the hospital and tell them that, they're going to tell you to come in. So, but you want to make your doctor aware of that. You don't want them to not know that the water broke. So if you can, you've got a mom who's really giddy and wants to go to the hospital, and you have control over the situation a little bit or some influence, you can say, early, however you're going to sugarcoat it to get them to stay home. It doesn't get any more enjoyable as you go, put it that way. Okay, so what's the second stage, emotional signpost of labor? Yeah, stoicism. She gets serious. The smile goes away. And I don't recommend it, but if you had her cross the street, she'd have to stop while she's crossing the street because attraction is so powerful. Third stage, the third emotional signpost. Yeah, she gets emotional. She might miss a dog or miss another child or miss, might get angry. She might get about something. So we see a change in the emotion. The emotion is just, it's like very serious, and all of a sudden we see emotion. So what comes after that third emotional signpost? The the emotional stage. They call that transition. What comes after that? What's she going to start doing soon? Or wanting to do? Push, yeah. So we know that pushing is going to come soon. Or she's going to be ready to push. Or if you're in that situation, you might want to check the dilation because she may be ready. She may be dilated, fully dilated and ready to go. Those are some things to consider. And that all comes, well, it kind of goes along with it, but the emotional signpost of labor kind of leads you to the delivery, to the actual birth. So what are the actual stages of labor, though, that we discuss in the book? What is the first stage of labor? Yeah, dilation. So what we see happening here is that we have the two hormones. What are the two hormones? Estrogen and progesterone. Estrogen is going up, progesterone starts to tail off, starts to decrease. That activates the oxytocin receptors on the uterus, right? Oxytocin starts causing what within the uterus? Contractions. So the uterus starts. As the uterus contracts, it's squeezing the baby downward. Now, hopefully by this point, the baby has turned. Okay, so for most of the pregnancy, well, when the fetus is relatively large, it's head up. Head is superior. The feet are down below. Closer to delivery, the baby will eventually turn and be head down. Sometimes the baby doesn't turn. Sometimes the baby's not cooperative. That's not a very pleasant thing because then you have to talk about all these other. A lot easier if the baby just cooperates. Have a child where the baby's head didn't go down. Happens. Sometimes it does. Yeah, sometimes it takes a little
I'm
bit.
talking like 36.
Yeah.
It was pretty late.
Yeah.
We kind of
Yeah.
But I was breached.
Oh, you were a twin.
Yeah.
We're a whole world of mess, huh?
Yep.
So you had a twin and
Yes, I was supposed to be older.
okay. Identical or
No.
fraternal? Or breach.
Yeah.
Born breach because you were sectioned out.
C-section.
Babies can be born breech. They can. It's just it's a little tougher on everyone. Yeah. So usually the baby will turn head down. All right. So what happens is the baby's head then will start to push on the cervix to stretch the cervix, and as the cervix stretches, obviously it's going to dilate more, which is going to cause more contractions. So the more contraction, the more the dilation. Get to dilation, which is how many centimeters?
Yeah.
10 centimeters. Yeah. Thumbing your forefinger like this, you go in and you check. You feel a whole bunch of baby's head. Oh, we're ready to go. All right. What's the next stage of labor then? Expulsion. Yeah. So that's when the baby comes out. Third stage of labor then? Rarely remembers. Placental stage, right. That's when the placenta. Doctor will take a look at the placenta, make sure. Arteries, no, 2 veins and 1 artery.
In
Home in Hawaii?
Hawaii, yeah, there's some Hawaiian custom that. And then at the kid's first.
Yeah.
They have. No, just take it and kind of
Oh, I see, okay.
like, but always like, it's a,
Oh, sure.
you know, we have a 1 year birthday. Pilgrimage to the family placenta.
Anyway, whatever you want to do with your placenta, I guess you can talk to the doctor. Hey, I'd really like to take it home and eat it. Back it up for you. All right, good. Kind of like when you get married and you freeze your cake for a year and then eat it.
Yeah, but
Did you save some cake?
I did.
You have a food saver? Vacuum sealer or something like that?
I cut it up.
Vacuum sealed it? It'll taste good next year. Vacuum pack your placenta.
I
You
don't
can eat that.
know. My Hawaiian friends didn't eat it, they just went, and I mean, it goes back, generations upon generations.
Yeah.
His dad's placenta is buried there.
Lots of placentas are buried there.
something-
Fossilized placenta, right?
Yeah. Like, what is this? Mom, look what I found.
Works, Okay. Comes to lactation. We have two hormones that are involved with lactation. And what are those two hormones? Prolactin is one, and what's the other one? Which one is the posterior pituitary hormone? Oxytocin, yeah, oxytocin posterior. So what is oxytocin responsible for? What does oxytocin do when it comes to lactation? Causes what?
Starts that positive
Yep, you get a positive feedback loop.
to produce.
Doesn't make the milk,
No.
it does something else.
Sells it.
It's a squirter, all right? So oxytocin is causing the ejection of it. This is what allows the milk to be released. The other one, prolactin, the milk producer. So that's the one where you'll see it actually creates the milk that the baby. Now, in most women, their body will be ready to produce the milk, but again, it's kind of like that inhibitory thing we were talking about. So estrogen and progesterone, mostly the estrogen, is kind of prohibiting the milk from actually coming in. So when the placenta goes away, well, this isn't entirely true because the mom can nurse right away. That isn't true milk, there's colostrum there. So when the placenta goes away and we see a significant drop off in estrogen and progesterone because that was being produced by the placenta, then we sort of take away the inhibitor of the milk production. So then that's when the mom's milk starts to come in. So that's why you'll see it in some expectant mothers. Some expectant mothers, their milk is come in and their milk is coming out before the baby's in. Guessing more often than not with a woman who already has had children. Based on what I've seen, most of the time when I've seen that happen, it's happened to a woman. You have other stories to tell me? All right. Oh. Yeah. All right, so going back to what we talked about last week, we have two layers to the oocyte, the egg. What's the outer layer? Corona. Yeah. Which means what? Rays of the sun doesn't mean the sperm. Sperm have to get through it. Rays of the sun. Oh, remember, that's the outer layer. And then what's the inner layer? Zona pellucida, ZP, right. So the sperm has to get through the corona radiata. Once it gets through the corona radiata through enzymatic action, remember, we have enzymes in the head of the sperm, that's the acrosomal reaction. So it sort of allows the sperm to burrow its way in. The sperm also goes through a process called capacitation, where it's, instead of swimming forward, it starts to go back and forth more vigorously. Zona pellucida, now the zona pellucida draws it in, remember? Have zona pellucida, the ZP, drawing the sperm in. And then once the sperm makes contact with the actual egg itself, what happens? Egg hardens, preventing what?
Any other sperm?
Any other sperm from coming in, which is called what? Nope. What is it?
Meiosis.
Polyspermy.
Okay.
Polyspermy. That's polyspermy. Now you're on the right track. Once the sperm enters the egg, now the egg is going to undergo what? Mitosis 2, which is involving what? What's happening? Got 46 chromosomes in the egg. The sperm took its 23 and introduced it to that 46. That'd be 2 minutes, right? You were giving us the math last week, and people were laughing at you, but you were right? You knew how
Kicks
many.
out the other 23.
Right, so we have to kick off the other 23, so we have 23 from the mom, 23 from the dad. So the 23 come off in the polar body. So that division of the chromosomes, 46 in the egg to 23, that's the meiosis 2. Now, meiosis 2 also happens in the sperm, except it just becomes 2 different sperm, whereas in the egg, it just gets cast off. It does. Difference. We'll talk about that next week. We come back to that meiosis and mitosis. All right, so then we have that. So once we have the merging of the 2 pronuclei, that's called a what? Zygote. Yep. So then the zygote starts to divide. And it divides and forms this cluster of cells, and those cells are called what? Nope, close. Blastomeres. Blastomeres. Cluster of blastomeres looks like a mulberry called a morula, right? Yep, the mulberry, the morula. Then the morula hollows out, and then morula to something called a blastocyst. Remember cyst? Fluid filled. Blastocyst has 2 areas to it. It has an outer, kind of like, think of it like a hollow rubber ball. The actual ball part of it is called the what? Trophoblast. And then we have a little chunk of cells hanging onto the inside called the cell mass. The trophoblast becomes what part of the developing organism? Yeah, eventually become the placenta. Yes, through the way of the chorion, right? The chorion is the first. Cell mass becomes what?
Kid.
Yeah, you got it. Okay, so we have implantation of the blastocyst, which occurs after how many days, roughly, after fertilization? About 7-ish, yeah. About a week. Implants. The trophoblast starts to differentiate into 2 different parts. What's the first part, or one part? Cytotrophoblast, which maintains that circular. Yeah, the one that kind of eats its way into the uterus, which is called the
Syncytial.
Syncytiotrophoblasts. Syncytiotrophoblasts, yeah. That's going to eat its way into the uterus, and it's going to eat away or erode the walls of the mother's uterine capillaries, so that we get these fluid-filled spaces called what? L. Yeah, lacuna matata, right? So the lacuna with blood. Now we have the cytotrophoblast, which starts to develop these little finger-like projections called blank villi. Yeah, the chorionic villi. So we have the beginning of what's called the chorion. The chorion. And the chorion produces a hormone called Mom, Dad, how did I come to be in this world? Well, you know what? Started back when you were a cluster of blastomeres called. Tell this wonderful story. Okay, so anyway, so the chorion produces the HCG. So what does the HCG do then? It rescues something. Ovary. Got it, the corpus luteum. So it rescues the corpus luteum. Corpus luteum. Estrogen and progesterone, which does what? Serves the uterus. So that way the embryo can continue to develop. So now we have this inner cell mass, and it starts to differentiate. We start to see a top layer. Well, we see a bubble on the top filled with a fluid called amniotic fluid, but we have this little flat layer of cells. Layers. Call this the bilaminar or bilayered embryonic what? Disc, yes. It has two layers to it. What are the two layers? One's above. Epi. Epi is above. So the epiblast and then below. Hypoblast. So the epiblast and the hypoblast. And what happens? Paper. Yeah,
2 goes to 3.
doing this. What's this called? Yep, you got it. What is it called? Gastrulation. Yep, we have the formation of something called the primitive streak. Yep, primitive streak. So we see the pushing down of some of the cells of the epiblast. So now instead of 2 layers, we have how many now? 3. And what are those layers called? Yep, ectoderm, endoderm. So the ectoderm ends up becoming what parts of the body, essentially? Nervous system, right. The superficial, the shell of the body. Yep, you got it. We have the formation of the neural groove, which turns into the neural, and then will become the brain, and then throughout the rest of the body will be the spinal cord. Look at the nervous, when we look at the nervous system, if we think back to when we covered the nervous system, the brain is actually a hollow structure. It's got all the ventricles inside of it, hollowed out. And then we have a long canal down the middle of the spinal cord. So it's a hollow structure. It is a tube. All right, so that's the ectoderm. What's the mesoderm? What is it? Muscles, bones, heart, kidneys. Digestive system. Right. So when we think about when does the embryonic period end? 9 starts the fetal. And then, once we get to the fetal stage, what has yet to grow? What has yet to develop? Enter the fetal stage,
Everything's already developed.
everything's there, everything's developed. It just has to grow and continue to develop. By the time we reach the end of the embryonic stage and enter the fetal stage, all the body systems are in place. Even if it's just a rudimentary form, everything is there. 10 fingers, toes, 2 eyes, 2 ears, mouth, nose, cardiovascular system, kidney, digestive system, everything. Every system that's in the body might have discovered she's pregnant or is about to. So right. So I think that really does sums up what we talked about last weekend this week. What questions do you have for me?